Okay, thank you to those already online. We will just wait a few moments longer for those joining this live event to log in. So please bear with us for a couple of moments longer. Okay, I think we're good to start now. So I'd like to extend a warm welcome on behalf of the United Nations Institute of Training and Research from here in Geneva at the Palais des Nations. Welcome to this fourth episode of our Responsible Digital Health series. As we have done so in each of these webinars so far, I think it's important to frame today's discussion in the context of the SDGs, the 17 SDGs that all of the United Nations agencies committed to since 2015. The age of artificial intelligence, machine learning, and deep learning is well and truly upon us, and it stands to have a transformative impact in nearly all areas of life, and of course, therefore, across all of the SDGs. Whilst today we will obviously be focusing primarily on SDG 3 to ensure healthy lives and promote well-being for all, many of these issues that we'll discuss today, opportunities, challenges, have much broader relevance for all of the SDGs. During this session, we will take a look not just at the promise that these data analytical tools hold for the future of healthcare, but also highlight some of the key challenges and common pitfalls in developing ethically sound and fair AI for health. We will focus on the ethical and social impact of AI applications, particularly on issues of gender bias and racial discrimination that might result from or be perpetuated by poorly designed or trained AI algorithms, and what can be done to combat these. I'd like to remind all of our participants joining us live today to use the Q&A function on Zoom throughout the discussion, and we will try and address as many of your questions as possible at the end of the discussion. Without further ado, I would now like to introduce our first guest for today's event, Professor Virginia Dignam. Virginia is a professor at the Department of Computing Science of Umeå University, Sweden, where she leads the research group Social and Ethical Artificial Intelligence. She is a fellow of the European Artificial Intelligence Association and an associate of the Faculty of Technology, Policy and Management at the Delft University of Technology. Virginia is actively involved in several international initiatives on policy and strategy guidelines for AI research and applications, and is a member of the European Commission High-Level Expert Group on Artificial Intelligence, of the IEEE Initiative on Ethics of Autonomous Systems, the Delft Design for Values Institute, the European Global Forum on AI, the Responsible Robotics Foundation, the Dutch AI Alliance on AI, and the ADA AI Foundation. And in addition, Virginia quite literally has written the book on responsible AI, so I feel that we're in good hands today with having her in the discussion. Virginia, I'd like to welcome you to the series and thank you for taking the time for being with us today. The floor is now yours for your opening presentation.
Thank you very much. Thank you for your kind words. And I suppose my slides will appear magically. Yes. So talking about the responsible artificial intelligence, it's first very important to understand what AI is and also what AI is not. AI is more than just machine learning. It's more than just algorithms. But on the other hand, it's also very far from what we would think about an intelligent person. So AI is not intelligent. AI, it's about the ability and the taken to the extreme, and we see a lot of potential and a lot of very good results by using the power of AI to identify patterns in data, to correlate, find through correlation, find these patterns, and then use these patterns to predict new insight or give us new insights in other types of data. But because it's based mostly on these correlations, and we all know that not all correlations are as meaningful one as the other. So we really need to be aware of what are we doing when we are using this type of algorithms which correlate on data that not all the time is, or in many cases is not being used exactly or being collected exactly for that purpose of the systems that we are developing. And in other end, in many cases we are not really aware of what type of issues might be hidden in the data that we have. So when we talk about a responsible approach to designing and developing and using AI, the first question that we really need to ask is, yes, AI can do a lot and the potential of AI is very large, but what should AI be doing? In which type of domains, in which type of questions are we as people comfortable and trusting that AI is going to give us really a good answer? And if this is a question, who is going to answer this question? Is that the AI developers? Is that the clients, the ones who have the money and who ask for applications to be built? Is this a societal question that requires a societal answer? Is that so? The first, it's also important to realize who is going to answer this question. Who is going to decide when or not to apply AI? As we are taking this decision, then the issues are, which values are we going to consider? Purely economical values, purely efficiency values, or do we want also to consider the values of fairness, of transparency, of alignment with human rights, and all the other types of issues that many people have been discussing? When we have values that are not really aligned, when we have to decide between efficiency and accuracy, or between efficiency and transparency, how are we going to deal with these dilemmas, and how are we going to prioritize these values? So in the work that has been done by many different groups around the world on identifying what is responsible AI, the issues that come forward is, yes, it is about AI systems that have been designed and are being used in a lawful way, aligned with the laws and the regulations of the countries and the place where it is used. It's also systems that are aligned with ethics and the principles and the human rights guidelines that we all follow. It's also about systems that are reliable, that work as they say they do, and don't really crash or don't present any risks of safety. Of course, we would like these systems to be beneficial for a large part of the society. And moreover, we would like to be able, from a computational perspective, from the perspective of those that are developing these systems, that we can verify these properties. So it's easy to say we want a system to be fair. It's quite complex to verify first to understand what do we mean by fairness, and also to verify in the computer code, in the software, what and how is this fairness being developed. So the question is, like I say, about should we use AI? And AI systems, like I say, it's more an extending and encompassing, but extending machine learning systems. It's basically about systems that are autonomous, that they are adaptable to the environment, and that interact with us. And the software is not the only part of the system that we are concerned about. Of course, the AI software, the AI applications are a large part, but these are always inserted in a social technical system, in an environment in which you have the stakeholders, but also the institutions which can guarantee the properties and the behavior of these systems. So if we are talking about systems that are autonomous, we need to be able, in order to get the responsible AI, the trustworthy AI that we desire, we need to be ensuring that somewhere in this social technical system, and not necessarily only in the software, but also in the process and institutions around it, we need to guarantee responsibility. In the same way, if the systems are interacting with people and are really affecting directly actions and decisions for people, we need to somehow incorporate in this, again, in the social technical system, the instruments that ensure accountability, that ensure that things are explainable, are justifiable, and also that there is a possibility of account for potential risks or potential failures of the system. And finally, if the system is adaptable, it changes and modifies itself as it learns and as it interacts with the environment, we really need to have some level of openness or transparency to understanding how these changes are happening. If you move again. So just giving a few examples of how this ART, what the ART for accountability, responsibility can happen, are taken into account in healthcare and in medicine. So if you talk about accountability, is the type of decisions that we have to take when we have to decide to be accountable for a decision that we take as users, as the ones who implement and use these systems for patients and for clients. How do we justify using a system which is 95% accurate but cannot really explain the decisions that it takes, or a system which is provides 80% accuracy of diagnostic but is explainable? So both of them have pros and cons, and the accountability is not from the system, it's from us to decide, for example, in this type of to explain and to take the responsibility for this type of decisions. Which one are we going to use and why are we going to use? And now we deal with the cases in which the system is not able to provide the correct accuracy and potentially also not explaining why. In terms of responsibility, it's also our responsibility for the self-determination of patients and of clients. So it's not just about giving the client and the patient what is good for him or if it's good for her, but taking into account also the inherent right of all of us to be able to decide for ourselves. So the system also needs to take into account a dialogue with patients and the potential for patients and for clients to take their own decisions. It also has a responsibility in terms of the medical training. It's not anymore about training people in the medical profession about having the answers, but it's about training people to ask the right questions. AI systems in general are very good at giving answers. If we don't ask the right question, or if we are not able to interpret the answer, then we really need to change the training and the way that we approach the role and the capacities of the medical professionals. And then finally, in terms of transparency, it's not only about the data that we are using for training and for making decisions, but it's also about ensuring a transparency about the development process. How has this system come to be? Who has been involved? Who has been consulted? Have been patients being involved? Yes. Why? Why? If not, why not? And what are the type of governance processes, governance methods that we have in order to ensure that while the system is used and is operating, that all the consequences and all the aspects of the life of the system are taken care of through processes and through institutions that guarantee that the way that the system is used is sound. So we can take the responsibility for systems in many different ways. We can take the responsibility for the system in the design processes, also in the behavior of the systems. But what is very important to not forget is about the taking responsibility by ensuring the integrity and the certification and regulation that are needed for those that are developing and using this type of systems. And then we can go to the next slide. Because of most of the systems and opportunities, the applications that we see around for healthcare, but for other types of applications and domains as well, they are opportunities, and yes, they can provide a lot of good potential, and we really definitely should enforce and ensure that the good potential of the opportunities of these applications are there. But we really have also at the same time to be aware of the potential risks. So when we talk about chatbots and robots, is about issues of potentially mistaken identity. Does the patient still understand that it's talking with a machine and not with a person? But also issues of future of jobs. What are the future of the jobs of health professionals when they are replaced by machines? When we are taking systems that are going to make decisions and automated decision making or self-diagnosing and so on, we have to take into account issues of bias and especially of reinforcing the bias that we already have. About accountability, it's not the system, we cannot hide behind the system. We cannot just hide behind the computer says no, but we really have to have the accountable process. And of course, issues of privacy and of safety are often referred to. And I think I have one last slide. Maybe not. Yes. So there is a lot of work being done by many different organizations in the world, the European Commission with the guidelines for trustworthy AI, but also the IEEE with the guidelines for responsible and ethically aligned design, or the OECD with the principles for artificial intelligence, and many, many more. All of these type of documents and regulations and guidelines are not necessarily guidelines for the software, but are mostly guidelines for us, for the people around, for the institutions around it. And a lot of these guidelines are referring in one way or another to issues of healthcare and of medical domain in terms of the regulation, but also the self-regulation by the organizations and by the patients themselves in terms of how they deal and regulate the type of systems that they use, in terms of the data that is being used and the quality of this data, but also in terms of ensuring and requesting the universal access and ensuring diversity and inclusion in terms of all the potential users and people involved, and at the same time taking into account that we need more than just the data or the computational skills, but we really need to have a multidisciplinary approach that enables to understand not only the technicalities of the system, but mostly how can we deal with the potential impact in society and in the users, the people that the systems are bringing with them. And a lot of what is there in this type of guidelines are focusing exactly on this type of issues. Thank you very much.
Thank you, Virginia, for this excellent introductory presentation. I think you did the very hard job of giving a nice overview of what responsible AI looks like in a very brief presentation. I particularly like the statement on your last slide there, that AI principles are principles for us.
Exactly.
As the creators
the main,
and those
if you
that
don't
interact.
get nothing else from the presentation, this is the main message indeed.
Yeah. Okay, yeah. And I look forward to exploring in some more depth some of the issues you raised there later in the discussion. Yeah. Moving on now, however, I'd like to introduce our second guest for today, Dr. Anne Ertz. Anne has been head of Novartis Foundation since January 2013, an organization committed to having a transformational impact on the health of low-income populations. Anne holds a degree in medicine and a master's in public health from the University of Leuven in Belgium, and a degree in tropical medicine from the Institute of Tropical Medicine in Antwerp, Belgium. Anne has authored numerous publications and is a member of the Broadband Commission for Sustainable Development, the Governing Council of the UN Technology Bank for Least Developed Countries, and the International Advisory Board of the Commonwealth Centre for Digital Health. Anne, welcome to the series, and thank you very much for taking the time to be with us today. The floor is yours for your introductory presentation.
Thank you so much, Danny, for the nice introduction. And Virginia, I truly enjoyed your presentation and I learned a lot. I look forward to explore more. In fact, I am not an AI specialist, but I'm a simple medical doctor. And in fact, through our role at the Novartis Foundation of chairing the working group on health for the Broadband Commission for Sustainable Development, We have been working with experts around the world in both digital technology and data and AI to see how we can better help countries tap into the potential of these new technologies for their health and care. So our latest working group this year was chaired by us together with Microsoft, and we looked at how AI is already making an impact, a tremendous impact on the health of many people around the world, and how we can translate that into a roadmap for countries to advance on their readiness to deploy AI in the health systems. So why that in fact matters, we looked at the global health challenges nowadays are really unprecedented, and not only because of the increased healthcare spending that can be expected to double in the next 20 years, but mainly because of the serious health worker shortage around the world, and low and middle income countries are least staffed when it comes to specialists. For example, countries like Ghana, Kenya, they have a handful of cardiologists, they have 6 oncologists, while they, for example, have a third of their population suffering from high blood pressure. So you can imagine on what kind of a time bomb these countries are sitting. That, together with the rapid urbanization mainly happening in Africa and Asia, the dual disease burden in all of these settings, while infectious diseases are not finished yet, and the chronic diseases, the epidemic of chronic diseases has been exploding massively in low and middle income countries, with cardiovascular disease now the leading cause of death around the world. And next to that, COVID was just a wake-up call that we all live with this constant threat of new diseases that we will have to face in the world, let alone the misinformation and disinformation that is spreading like warm bread all around with social media and other channels. All of these challenges together in the health space nowadays are unprecedented. So it goes by itself that our current health systems cannot simply address all of this together. And that's not only in low and middle income countries, but also in high income countries, as we saw during the COVID crisis. So that is why on the next slide, we looked at what is AI already doing around the world. And in fact, the beauty that came out of this full landscape analysis, where we looked at 300 examples from all around the world, was that it came from both high and low and middle income settings, all of these examples. So it's not only the AI we know very well here in clinical care that is helping dermatologists, pathologists, or radiologists to make their diagnosis that is image-based more accurate or more rapid, but it happens all around the world already. And beautiful examples, top 5 use cases that came out of our landscape analysis were in population health, where models to help governments to track and predict epidemics before they occur, and when they occur, track where they will further spread, have proven life-saving during COVID, but they existed already up front with models like UNICEF's Magic Box, for example, that was already tracking the Ebola epidemic at the time. Preclinical R&D and development of drugs in clinical trials has massively undergone a change thanks to the data-driven AI optimization of discovery of drugs and of the way we can now perform clinical trials. It has become much simpler and much faster, and we can even approach many more people to make clinical trials much more representative from global populations. Examples of how AI can help in the discovery, there is definitely now with the COVID, again, in the beginning of the crisis in March, all healthcare industry partners, companies, I mean, have put their currently existing drugs in the same data pool to look at which of these drugs could potentially have an impact on COVID. And benevolent AI detected drugs that were currently on the market and that have now been translated into clinical trials and still running in COVID patients. So it can tremendously speed up drug development, which has become a real difficult thing to do now in the world. Clinical care, we know it, as I said, with image-based diagnosis has been the best example of AI as first improvements in the way we can deliver health and care around the world, but beautiful examples also exist outside of that. With, for example, Apollo hospitals in India is already having a fantastic way of how you can predict which populations in an entire population of a city, for example, which populations are at highest risk of an acute cardiovascular event. A risk score that outperforms the good old Framingham risk scores, which were based on non-representative white Caucasian male data. So you can imagine that was far away from being representative, as you were highlighting, Virginia. So now Apollo set out in their millions of data of cardiovascular disease in the Indian population to build a new risk score, drilling down 300 risks to then 40 and then 7 simple risk factors that can really identify who is at highest risk for a heart attack or a stroke 7 years in advance. And it's outperforming the Framingham risk score by twice. Currently being validated in the Netherlands, we are validating it in Brazilian data so that this kind of AI-driven solutions can become globally representative solutions. Patient-facing solutions, you mentioned them, chatbots, there's several examples, and in China, there's massively impactful examples of internet-based care, but with Ping An Good Doctor that is providing every family in China, or at least aiming to provide every family in China with a doctor, a health plan, and a health records digitally, and providing 24/7 services in internet hospitals, health centers, and pharmacies with even home delivery. They perform 1 million consultations per day and already have 300 million people in their customer base, so massively impactful patient-facing solutions. Optimizing health operations, many examples we know, you all know, I'm sure. One beautiful one is Corti, that in Denmark has developed a model that can really identify during a call which person is really at risk of having a cardiac arrest, and it identifies cardiac arrests based on voice and non-verbal clues in the call much faster than the caller can ever do. So beautiful examples of top use cases already running in the entire world with AI. Then based on all that landscape analysis, we looked at what are the challenges, the learnings and the insights, and translated that or grouped that into a roadmap for countries where they have to invest in if they want to advance on the readiness to deploy AI in their health system. And we identified 6 steps. And many of those came back in your presentation, Virginia. I was very happy to hear that. 6 steps are essential for governments to invest in, and they are equally important. You cannot invest in only one and hope that you get more ready to deploy AI in your health system. You have to advance on all 6 of those levels. The first and foremost one is people and workforce. Without increasing digital skills, both in populations at large and in workforce, health and tech workforce, we won't get there. So that's absolutely key. Data and technology, it speaks for itself, but it is still a major issue in the world that technology is not there. Half of the world is currently unconnected. So that's also the universal call of the Broadband Commission for increasing access to broadband for that last 46% of the world that still has no access to internet. In the world of today, now in the COVID crisis, having access to internet has become a question of life and death. So it's really important every country gets connected and taps into the potential of digital in its health systems. Data, obviously there's no digitized data available in all of the countries around the world, and where they exist, the quality is definitely not what we would like to be able to perform machine learning on it. But and data sits in silos, and all of the issues we know about analyzing data in a big data analytics way. So we need to remediate that and invest in right, clear architectures before we can tap into the potential of AI. Governance and regulatory, obviously we need to build systems in all of the countries around the world that keep the people safe and secure when they use AI solutions. And that's mainly the topic of today. But the fourth one on design and processes is what you were stressing a lot, Virginia, that it's really important that every solution that gets designed is needs driven. If it doesn't answer a real priority need in the country, it won't get to scale. We've seen that in all of the examples around the world. When it is a well-intended solution brought to a country without having asked the country or the end users, what are the priority needs you want to address with AI in your health system, they won't get to scale. It's as simple as that. And on top of that, it's really important that every solution is designed with the human at the center. The end user has to be involved. Patients or providers who will use the solution have to be involved in the design process if we want it to be successful. And lastly, if we don't think about the processes of how we will integrate the beautiful solutions we develop into health systems, we will face a lot of resistance. And that is absolutely to be avoided. So that's why from the beginning, from the design phase, we also need to define the processes for integration into the health system and the current process, the current health way of working in the health system. The fifth pillar or step that countries have to invest in is real building strong partnerships. No one can tackle this alone, and definitely not a public health system. It has to partner with tech partners, with other partners, all of the stakeholders that are needed in building a coordinated way to deploying AI in health. If that doesn't get coordinated by the government, if the government doesn't stay in the driver's seat in low and middle income settings, we will end up with fragmented landscapes of, again, solutions that sit in silos and don't speak to each other, just like we've seen in the digital health space. So that's to be avoided. And lastly, if governments don't have the necessary funding to invest in AI solutions for health, they need to make sure that they are open to innovative ways of incentivizing innovation or to innovative ways of monetizing data and their assets. So that are the 6 real steps all governments have to invest in, equally important to advance from being in the exploratory phase to an emerging phase to an integrated ecosystem. Building that entire ecosystem ready to save lives and to improve efficiencies and patients' participation or engagement into their own, the management of their own health. So AI in health, let me end by saying that it is really a global emergency, that we all take this as a priority, both globally and nationally, so that AI can become an integral part of every health system that is as essential as hospital beds are. But obviously, we need to make sure that that happens in a safe and secure and responsible and transparent and accountable way, just like you were explaining, Virginia. So that was in a nutshell the content or the highlights in the report of the Broadband Commission, which we are now translating into a self-assessment tool for governments that they can map where they stand in their readiness to deploy AI in the health system, and then also understand what are the priority investments they have to make to advance on their maturity. So the last slide is really showing who was, the next slide please, who was part of this working group. We had several experts, from external experts involved, as you can see on all of these, with all these logos, and then the broadband commissioners who were part of this working group. You can see on the left hand, most of the UN agencies, but a lot of private sector partners as well, the African Union, the European Union, and at the right hand side, you see many other experts around the table that contributed to this. So for those of you online, thank you again for your contribution, and also thanks to everyone for the attention. I look forward to the discussion.
Thank you, Anne, for a brilliant presentation and highlighting some of the key opportunities, but also actually some of the ways that AI for health is already being realized in some settings. And I think also for highlighting the importance of a collaborative effort such as the one that's been undertaken by the Broadband Commission. I think without including all the relevant stakeholders from all sectors, it's never going to happen. We're never going to have the kind of transformative change that we need to make AI an integral part of our health systems for the future. On that note, I'd like to transition to the discussion portion of this session today. As I do so, I'd like to remind our participants as well that they can keep sending in their questions, and we will put those to Anne and Virginia when we have time at the end. Virginia, I'd like to come back to you with my first question, if I may. Anne has very nicely outlined for us some of the key opportunities for well-planned and developed responsible AI solutions in health. But thinking now about some of the potential problems of irresponsibly designed AI, specifically, could you please give us an idea of some of the negative consequences that come from developing AI solutions based on biased or unrepresentative data sets? And how can we avoid building biases into AI health systems?
Good question, difficult question to answer, but it's a question which we really need to address. Indeed, bias is one of the main issues. Bias is not something which we really can avoid. A lot of what AI does is based on biasing, on classifying. So the whole idea of classification, it's deciding whether something falls in a certain category or another. So there is a lot of it. It's guided by some way bias opinion on what makes a certain category or another. So it's difficult to completely avoid bias. What we really definitely want to avoid is prejudice, and on the other hand is also the privilege that some might get from gain from using systems which are not inclusive or diverse enough. So for a lot of these issues, they don't come intentionally. It's not that people are going after trying to find out the doing things in the wrong way. It happens very much naturally, and also happens a lot from the type of data that we are collecting. Like I said before, a lot of the data that we use for training and for informing AI systems is not explicitly collected for that purpose. It's data that exists from all kinds of other issues. And just a small example, some time ago there was work done on developing an AI system which could identify or indicate whether a certain scan image was indicating a cancer cell. I believe it was on breast cancer issues. The system was trained with existing data. What took some time to realize is that because of the way that that data is not only collected but also produced. So if the doctor expects or suspects that someone has breast cancer, is much more likely to send that person to a scan of a higher quality than when they just do a routine breast cancer triage or routine scans of every woman that happens in many European countries. So the AI system, because it correlates and it doesn't really understand what it's doing, like I say, AI is not intelligence, the system very quickly learned to correlate breast cancer with high resolution images. One thing has nothing to, or it has to do, but it has much more to do with the idea that the doctors behind had of sending people which had a higher suspicion of cancer to those higher quality machines. So these are the type of things which we can say then it's biased, but it's in a sense inherent not only on the data itself, but also on the way that we are producing the data. And like this one is one which we use often in education to tell our students how these things can naturally happen. But there are many of those, and many of them which we not even know exactly where this correlation is happening. And we do see that the correlations work, but that's what makes it difficult, because we don't really all the time understand what is the explanation behind it.
Yeah, I completely agree. And it kind of reminds me of a discussion we had in a previous week's webinar talking about inequities in digital health more generally, and the message being that digital health inequities exist as long as health inequities exist, and as long as these bias exist in our society, then we will incorporate them into AI solutions as well. I think you made a good point there about once we learn, and it comes back to your point about once we learn the right question, we can get the right answer, and once we learn what the biases are, we can correct them in our solutions. So yeah, I think that's definitely one of the biggest challenges going forward. And I'd like to turn to Anne now and perhaps ask you, what do you see as some of the other biggest challenges that we have in advancing AI technologies in health systems?
The biggest one was that's a difficult question, obviously, because there's so many. But I think the example you just gave, Virginia, is definitely one of the most important ones. The integration process has to be thought about, as we saw in our landscape and our roadmap. If you think about how the solution is going to be integrated in the workflow or the process flow in a health system, then you can avoid that kind of bias already, or that kind of prejudice that it's only those patients that are already suspected by a medical doctor for having a problem that they are getting this high resolution scan. So it's really important to think that out. But the main challenge in low and middle income countries are, for me, the two first ones in our roadmap: the people skills, so the digital skills of and data science skills of populations and the workforce as well. And secondly, the availability of data, besides the connectivity, of course, that has to be solved first, but the availability of the quality data that you can use machine learning on is going to be a big stumbling block, because many countries are still paper-based. We have to realize that electronic health records are not universal at all. And those countries that have electronic health records, they face these enormous diversity of non-interoperable data sets that are not talking to each other, that costs even more to invest to clean those and make them interoperable to be able to use them for AI solutions. That's where low and middle income settings may have an advantage, as they don't have to cope with that legacy system of non-interoperable data sitting in different silos, and they can build upfront the right health data infrastructure that can make everything combinable and interoperable. So that is an advantage for those who are still behind. But as you said, Dani, I think the inequity that already exists will definitely be included in the digital inequity. But I feel digital inequity has become the new, or digital access, lack of digital access has become the new phase of inequity. And that is a major challenge we now have, to make sure everybody in the world gets access to virtual services, because we see that it's not going to be solved. The health problems around the world are not going to be solved by the existing health systems. It's simply impossible. We have to centralize expertise, because we don't have enough expertise around the world, and the only way you can do that is with virtual care, and then augment those models of telehealth that can be very mature models, but innovate at the edges of these mature models. I think that's the opportunity we have for innovating with AI. We've seen in Rwanda a beautiful example of how AI can help the call responses in the telehealth centers to make better recommendations to the ones who are calling in, because they get AI triage and AI response that is really filtered, so that you can have non-skilled people responding to the calls and doing the triage, where before you needed nurses to do the triage. So that already saves a lot of the skilled health professionals for the task they are best placed to do. And it gives time back to doctors to spend with their patients, the things that they love most in general. So yeah, there's a lot of challenges, but I think the people skills, the data science skills, and the data quality are going to be the biggest hurdles.
Yeah, I completely agree. And I think, when we think about creating new inequities in health, and you mentioned that digital health could be the next big problem, and I think it is, in a way. Digital literacy is already limiting impact in some cases. It's really our job now to get ahead of that and fix that before it becomes a bigger problem than the health inequities we've tried to solve through digital solutions. I think another key challenge for the adoption of AI, particularly in a timely response to an acute or emergency situation that we've seen now, is a lack of standards or legal and ethical use of AI. And perhaps Virginia, I'll turn to you here, and you can tell us what's currently being done to ensure that robust and ethical and legal frameworks and guidelines are in place to support the development and application of AI for health.
Virginia, we don't hear you. You're still on.
Sorry, sorry. Yes, there is a lot happening in terms of guidelines, in terms of recommendations for regulation. There is not so much yet happening in the regulations themselves, but there is a lot of work around defining and discussing what are the type of regulations, what are the type of guidelines that are relevant for different types of aspects of AI. So not only the European Union is doing it, but at the level of OECD, and the OECD just very recently launched, together with the G7 countries and other organizations, the Global Partnership in AI, which is hoping to create really guidelines for governments, to help governments support their own decision making in terms of what would they want to define or to decide in terms of their national approach to ensuring the data issues, but also the labor and expertise issues, in terms of the opportunities for innovation and so all those type of issues. Each country will have its own balance of what is important and what is relevant. But this global partnership in AI hopes to create, in one hand, raise the awareness by the governments, but also provide the tools for all governments around the world to really start thinking about how can they facilitate and enforce a responsible and trustworthy use of AI. But also other organizations, the ITU, the International Telecommunications Union, is very much focusing on supporting and facilitating what has been known as AI for good, so defining and supporting and facilitating those applications of AI that directly benefit and enforce the global sustainable development goals. UNICEF, I've been working with UNICEF for 1.5 years now, also defining and supporting inclusion and deciding what is beneficial AI for children, and how can AI be supporting children in a way that it protects children from the potential risks of AI, but at the same time provides and empowers children by the use of AI in education, in healthcare, in all types of issues. So there is a lot of activity around the world, and I only see that it's growing at this moment. So there is a lot of interest from all areas, and it's not only something which happens in the global north, but especially in the low and medium income countries. There is a lot of activity and interest for this type of issues.
Yes, as you say, it's very encouraging to see that a lot of work is being done, and it's not just work being done to innovate AI for the sake of it, but actually now we're taking a more pragmatic approach, and ultimately these things will lead to building trust in AI as well, and therefore hopefully improve the quality of data available for us it's a self-sustaining cycle in a way, and hopefully it's the start of a more sustainable future for AI in health. I realize that time's moving on fast and there's lots of things that I want to cover, but I have said that I'll give some time for the audience questions at the end, so I'll move as quickly as possible. And thinking about the kind of low resource settings that Novartis Foundation typically works in, obviously there are big challenges there for access to affordable healthcare, particularly for management of chronic NCDs, for example. How do we ensure that digital and AI solutions are appropriate and affordable even in these settings? And linked to that, I guess I would ask, are health insurance companies responding fast enough to the growth in the digital health sector, but specifically in AI for health as well?
Well, that's a really good question, because it is truly necessary that we get access improved. But if you say access to affordable care, I would like to add an adjective: access to affordable quality care. You know that in the world, last year with the National Academies of Science and Engineering and Medicine in the US, we did this report on quality of care around the world, and we looked at there's many more people around the world dying because of low quality of care than because of a lack of access to care. So it's really a question of increasing quality of care. And I'm a true believer that digital and AI solutions do exactly that. They can improve the way we deliver care and health. And in increasing the access to expertise by virtually delivering health and care, you can definitely improve quality. We've shown that in our telemedicine programs in Ghana, for example, that have been then scaled to become national telehealth services, where we saw that you definitely you coach health workers on the ground which are less skilled, or even village health workers. You can coach them through their patient care through telehealth. And with that, you give access to people who live in areas who cannot reach the hospital or an urban center, to get access to quality care thanks to the expertise of the people in the telehealth center. So I'm a true believer that that works. And then, as I said, telehealth augmented with AI at the edge is even better. However, health insurances have been, at least in low and middle income settings, I don't know in high income settings, but have been lagging behind because telehealth services have never been reimbursed. And unfortunately, because it is definitely cost saving, it is definitely improving outcomes for patients. So health insurances have everything to gain to reimburse virtual care. And that is one of the beauties coming out of the COVID crisis, that that is now a given. Telemedicine has to be reimbursed. And I believe the US was the first one to set the example, but now many countries have followed to increase their health insurance coverage in a similar way for virtual care. And AI solutions, I don't know how far we stand there, but I definitely have hope that once it is demonstrated that you can gain both outcomes and costs, it definitely makes sense for an insurance to cover it. So I believe it is feasible. That being said, in low and middle income settings, I think there's a lot going on. As Virginia says, that's true. Low income settings have the most to gain from AI in health, but they also have the most to lose. If they don't invest now in these right paths that we just described, they are going to lag behind and increase the digital divide and the health inequities that go with that. So it's really important that we don't do that, because then we leave exactly the most vulnerable again behind. So that's not what we want to do. I'm not sure if health insurances only are the answer then. It is really a multi-stakeholder approach. You have to work together between public and private sector, but also between health and tech sector, not only thinking the health sector can solve it all. Or then the education sector or the workplace, the work environment sector, all of that is very important.
Yeah, thank you. Absolutely. I think we need to be creative is the answer then, not only in our solutions, but in our financing models. And these kind of innovative financing models you presented early on, I think are the key. Virginia, I have one last question for you before we turn to the audience, if I may. I'd like to know realistically, where is the future of AI taking us? Obviously, predominantly at the moment, we see a lot of image analysis applications for AI for diagnostic capacity, for example, but is it likely to significantly change in the near future? Will there ever be a time when patients receive direct consultations with a fully digital physician, for example?
Yes, I don't know. I don't know if we want that future in which we will get the diagnosed even before we ask for it. So I don't know. It's also, like I say, it's an issue of taking into account our own self-determination and autonomy as patients. So I wouldn't want to go to a world which solves my health problems without me being involved in that process. So I think that, but in other hand, I think Anne already showed a lot of the issues in which AI can really provide a very good, a very beneficial contribution to the healthcare and the health issues and problems at this moment, and the divide in terms of the ones who have it and the ones who have not. We will see more of that. We'll see a lot of it based indeed in data analysis, image recognition, but also other patient records and things like that. But at the same time, I think that we will see increasingly an approach which is a combination and is not only replacing the experts, but also empowering or enhancing the capabilities of patients, of users, of health professionals, in a way that they all can focus on their main skills and get the enhancement from AI for other types of skills or other types of issues which are not your main expertise or your main concern. But I think that this enhancement approach will be seen more and more, together with all the possibilities that we have of using data analysis in patient records and images and other types of data to support and to increase the power of the quality of diagnostics and the power and the quality of healthcare in general.
Yeah, I fully agree. And I think one of the key areas is, as you say, empowering the patient themselves to take charge of their own wellness and health is a key step. I'm going to sneak in one last question for Anne before I turn to a couple of questions from the audience as they're quick questions. We've mentioned today a couple of times about the importance of digital literacy and digital health literacy, which leads me, Anne, as a question for you. Having trained as a medical doctor yourself, in your opinion, should more digital themes and AI capabilities become a core part of medical curricula for both doctors and nurses? Is that their role? Will it ever be their role to know these things or not?
Oh, I think definitely, Danny. I think it's digital savviness, at least. Not every doctor has to be a data scientist, but has to understand what you can do with data and what kind of assets you can develop. In fact, we all had to study statistics in our medical curriculum. So we had to learn about what tests are available to demonstrate that your evidence is really valid or not. So I think that definitely has to be part of every curriculum, the data science understanding, not that they all have to be developers of AI solutions, but also the savviness, the understanding of what digital can do to change the way you deliver health and care. Because I really believe we need to change our health and care delivery, not only improve it, but also bring a lot of the things outside. Just like to engage patients in their own care, most of the patient care should be delivered in the living room of the person and not in the hospital anymore. Even in low and middle income settings, this is very feasible. We used shopkeepers in Ho Chi Minh City, for example, to measure blood pressure of everyone who came to the manicure salon, the barber salon, the marketplace, the post office, the bus station. We trained people who were absolutely no health skills professionals to measure blood pressure, and then with automated Bluetooth, the positively testing people were directly referred to the health system. But the shopkeeper was also trained to deliver the right information. You're doing good, please keep going, or you're really bad, you have to make sure you eat less salt, or whatever was needed to give us information. So it's absolutely feasible to detect earlier really life-threatening risk factors of people in settings outside of the health system. That is definitely part of the solution. And there, digital or all the things we now have, the Internet of Things and all the AI solutions can really help us. But also in the hospital and healthcare centers, AI is an absolutely golden tool for triage, for more accurate diagnosis in the cases that it's already feasible with images. We're even building a tool to walk the last miles to eliminate the oldest disease known to man, leprosy, with AI. We use skin images and send these to the cloud to get a probability back on this is a chance that it's leprosy, please go and get treated. So it is really possible to do so many things outside of the health system, and that's going to be the answer to many of our problems nowadays.
Excellent. I couldn't agree more. I think not every doctor or nurse needs to be able to write their own algorithms, but they at least need to know what data is important and what the result means, just as a surgeon would know looking at a radiograph what it means and how to interpret it. A couple of quick questions from the audience before we finish. One here is, how can the development of programs related to health, such as WASH, water sanitation and hygiene, incorporate AI into them?
Maybe if I can give a start of answer. One of the ways that we can incorporate AI in these programs is in the part of the training and awareness. So we can develop AI systems which support and help people to know more about sanitation and hygiene, and also do that in a way that it's personalized or it's adapted to the specific conditions and context in which people work or work and live. So that would be one of the things to do. There are also a lot of efforts based on using AI technologies or database technologies to understand or to better predict the use of water and use of sanitation infrastructures in order to be able to address and to predict potential problems in the future, in which then like water shortages, and if you can predict that beforehand, then you can maybe address it in a better way. So there are different types of options here.
Anne, would you like to add to that, or can I give you another question to answer?
Yeah, please go ahead. I think our time is almost finished, and I see we have Mr. Mehta joining as well.
Yeah.
Yes. Thanks, Alex. I just seen you joined there, so I'll hand over to Alex in a moment to give the closing remarks. But just a couple more questions, if we may. One question for Anne is, how adept are different healthcare systems when it comes to evaluating AI-based technologies to decide on reimbursement? Because without reimbursement, it will be hard for patients to access these technologies, especially in LMICs.
Oh yeah, I think there's still a very big room for improvement, definitely. But I think governments that are willing to be that are visionary enough to commit to it, can do it. So like the example I used for Rwanda with Babil, for example, that uses telehealth and then augments the capabilities of the call responders with AI. This is a government partnership. So if the government wants to do it, they can get there. And even if national insurance schemes don't have enough funding to reimburse everything, there's a possibility to find business models that are feasible for the business to grow, that are still affordable enough for people. In Rwanda, there's a third of all the adult population is already connected to that service. And I believe they have an out-of-pocket fee of $1 per year or something. So that kind of business model, thanks to the partnership with the government, is really feasible. And it's a beautiful example. But I don't have many examples of reimbursement yet in low and middle income settings, I have to say.
Hopefully a growing domain. One question from Nina Knox is how to best get involved with the Broadband Commission Working Group on Digital and AI. And perhaps, Anne, you can check out the Q&A section there to pick up her email and respond directly. Yeah. And I can answer one last question here, which is regarding recordings of our webinars. You can find all of the webinars of this series on our YouTube channel. So if you just search Unitar on YouTube, we have a playlist of the Digital Health Speaker Series. So please feel free to check that out. I'd like to thank the speakers, first of all, and the participants for joining us today. And please join us next week for the next subject, which is on pilotitis, a digital health epidemic, which promises to be very interesting and perhaps is something some of you may not have even heard of. So there we go. Hopefully you'll join us next week. And I'll hand over to Mr. Alex Mejia to make some closing remarks.
I'm having some connection problems, Danny, so if you can close, that would be very good. But thank you to all the speakers indeed. Excellent. Thank you.
No problem. Thanks, Alex, and thanks for joining us anyway. Okay, great. So yes, thanks again to Professor Virginia Dignam and Dr. Anne Ertz for joining us today. Thanks to all of you for listening in, and I wish you all a very pleasant day. Goodbye.
Thank you so much. Bye-bye.
Thank you. Bye-bye.